Professor Ulrike Schmidt, many thanks for taking part in this Spotlight video. Just to start off, can you tell us a bit about your background and your work at King's College London?
Yes, I'm Professor of Eating Disorders here at King's College London, and I'm also a consultant psychiatrist in the Adult Eating Disorders Unit at the South London and Maudsley NHS Foundation Trust. My research focuses very much on developing and testing better treatments. By this I mean treatments that you can deliver earlier, that have better outcomes, that are more targeted, or that are able to reach more people. And if you want to do that, you also need to think about the factors that cause eating disorders, that drive people into eating disorders. So in parallel, we do a lot of research into psychological, biological, and societal factors that conspire to make people develop eating disorders, and that also contribute to keeping people locked into an eating disorder. So that's what I do in a nutshell.
Thank you. And we'd like to talk to you today to discuss the impact that the current pandemic is having on those with eating disorders. And that's thinking about, I guess, the different aspects of the situation, such as isolation or living in lockdown with family, the power of media at this time, and the inability to access services in the usual way, and what this all means specifically for this group. So how do you think the pandemic and the measures taken to curb the spread of the virus are affecting those with eating disorders?
Broadly speaking, we have two groups of patients. We have patients with anorexia nervosa who are terrified of gaining weight, who restrict their food intake, and who, when stressed, tend to lose more weight. On the other hand, we have people with bulimia nervosa, binge eating disorder. Those are very related to obesity, or can be related to obesity, where people are experiencing really distressing episodes of losing control over their eating. And sometimes they try to counteract them with extreme weight loss measures. So those two groups of patients broadly I will consider. Now, like all of us, the lockdown conditions you've mentioned factors like isolation, but also disruption of your usual routines, lack of structure, boredom, all those factors, the uncertainty of the whole situation, the bad news that you hear day on day in the media really leads to rising stress levels in all of us, but in conditions like eating disorders, which are very much stress-related conditions, it leads to a worsening of symptoms, typically because eating disorder behaviors become very habitual and become a little bit like coping mechanisms. So that's just across the board. However, then certain aspects of the lockdown and also of the associated rules and guidance affect different patient groups differently. So, for example, the actual food shortages or perceived food shortages were really difficult for our patients with anorexia nervosa, who often eat a very limited range of safe foods, and not getting access to these, it's hugely distressing. And I know that some of them just said, I can't eat anything then, and would go on to losing more weight. So very, very difficult for people. On the other hand, people with loss of control eating, bulimia, binge eating disorder, the advice not to go shopping for food more than once a week is hugely problematic. And people have said to me, I tried to follow that guidance, but then I bought my food and I ate it all in a day. So people then felt they had to violate these rules, and that would be difficult for them, and worried about getting infected. So really, really difficult to stick to this once a week going shopping rule. Then we both know that the media have been full of advice, guidance on food, eating, exercise. That's all hugely triggering to our patients. So all these endless cookery programs for how you cook in the lockdown and so on, but also endless advice on how to exercise, etc. Our patients kind of often do exercise, and some of them excessively, and the fact that the advice was to just do this once a day and go out, also hugely difficult for some of our patients to deal with. Then, of course, there is the issue that we know from a lot of research that unhelpful social media use can perpetuate eating disorder symptoms and make them worse. And of course, we've all been glued to our computers in these times of isolation. And so some of our younger patients in particular then become much more vulnerable to using social media unhelpfully, again, doing a lot of social comparison on social media where they sort of unfavorably compare themselves with other people and kind of end up feeling worse and driven into their eating disorders more. But the other really important change is, of course, that many people are sort of suddenly being brought together with their families, and that's both a huge plus, but also can present a huge difficulty. Certainly in the eating disorders world, we see families as really important in helping people to recover. A lot of our patients are young adults. We all know that young adults have been particularly hard hit in the job sector, being furloughed, losing their jobs as they're often the last one in. And this applies to a lot of our patients. So they suddenly find themselves back as young adults with their families. If they have tried to seek treatment away from their family, suddenly they feel much more in a childlike position, more under scrutiny. That in itself may present huge problems, may lead to discord and tensions in the family. The positive can also be that, of course, people then have some access to support from the family, that there's more of an opportunity to eat with family members and to kind of use all of that in a positive way. But it depends on individual circumstances whether this works positively and is a help or becomes a hindrance and contributes to distress, where perhaps there isn't so much privacy and people feel more under scrutiny. So those are just a range of some of the issues that our patients say to us when we talk to them that are affecting them in these current days.
Yes, thank you. So a lot of different aspects of the current situation which could be problematic, and maybe a few which could also be helpful, maybe in some ways. So in terms of accessing services during this time, what are we seeing so far in terms of how people are able to do this? Have they been able to continue with treatments and therapies? And have anyone who haven't accessed before actually been able to start treatment or therapies?
As you know, nationwide, the NHS was instructed to kind of pause routine work and to focus on very urgent work only in order to kind of focus all efforts on the immediate crisis. So what this has meant for eating disorder services up and down the country is that inpatient provision has been curtailed and bed capacity has been reduced because there have been fears that there might be outbreaks of COVID-19 in inpatient units. So a lot of patients who previously were inpatients have been discharged very rapidly, and some of them prematurely. Day services have been halted and routine outpatient work has been halted. And gradually now we are very much trying to regain a degree of normality and restart therapies that have been halted, and to support people who have been discharged at an earlier stage than you normally would, by having lots of remote conversations with them, trying to manage infection risk with the need to support and treat people who are physically often very unwell. So it's been a really difficult balancing act. What we also know from the media is that BEAT, which is the National Eating Disorder Charity during the time of the COVID crisis, has seen a 30% increase in calls to its helplines from patients and from carers who have experienced deterioration of their symptoms or have seen that in their family members and loved ones.
Thank you. And you mentioned a figure there. We were wondering, is there any research looking at people with eating disorders in similar situations that we can draw upon to help support this group at this time? And is King's doing any research in this area as well in the current pandemic?
I don't know how good the similarities are, but there is a little bit of research on women in prison. And what is known about women who are locked up in prison is that in the first year of imprisonment, they tend to put on a lot of weight, which is due to physical inactivity and combined with stress and boredom. So there are some analogies here. And there's also one or two studies out there which suggest that about a third of women who are incarcerated then develop eating problems, disordered eating. So the first kind of pointers towards an eating disorder. So I think this would show us that there are really some kind of parallels perhaps to what is going on now. In terms of the second part of your question, are we doing any research? Is there any research out there that on the current situation specifically? We are very much working on that currently. So we have contributed to developing questions around eating disorder symptoms in the context of several large cohorts. The EDGI study, which is here at King's, which is a genetic study, it's on the King's website, has lots of questions on how people are affected in the current situation, and various other large clinical and non-clinical cohorts. And we have also contributed specific questions to around eating and eating disorder symptoms. And these surveys are going to be repeated over time so that we really will be able to have a very fine-grained understanding of the effects of not just the immediate crisis, but also effects in the longer term. In addition to that, some of my PhD students and postdocs are currently doing a piece of qualitative work. It's a study that's out there trying to learn about the experiences of people with eating disorders up and down the country who can write in and just talk about their experience in the current situation, how the lockdown is affecting them, how specific aspects of this are affecting them positively or negatively, how they're coping in the situation. And the preliminary kind of interest we've had in this study has been very positive, and people have given us very detailed and very heartfelt accounts of how hard this has actually been for them.
Great. So it sounds like there's a lot already kind of going on to try and really understand how this group are affected by the pandemic and to help in the future. In terms of treatment approaches, how can they be adapted to help those with eating disorders during this time? Because we were mentioning earlier how obviously the access to normal services is just not the same as it was before. And are there digital or virtual therapies for eating disorders already in use? And how do they compare, I guess, to face-to-face approaches?
So our group has been at the forefront of developments on remote treatments for eating disorders for the last 20 years. So this starts most basically with translating some of our face-to-face psychological treatments even into workbooks for people that they can do at home. So this is even before the era of virtual or online treatments. And what we have shown for people with bulimia, but also for people with anorexia, that the patients can work through these workbooks by themselves with some guidance from clinicians. This guidance can be face-to-face, but it can also be by phone, by email, or by video link, and can get good outcomes and achieve full recovery from their problems. Now, in addition to that, we have a long track record of using structured, mainly cognitive behavioral online treatments that combine kind of self-guided learning, looking at text, looking at videos, doing exercises online, and being your own eating disorder therapist. Again, works better with some guidance, and it's only for patients who are quite motivated to do this work. And what people tell us is that they like these approaches and they like the flexibility of these approaches, but what is harder is to motivate yourself to keep it going. So that's also where guidance from a human being comes in. Now, the last group of adaptations is to do with video conferencing. And there had always been a couple of studies that showed that actually treatments delivered by video conferencing, and these were studies coming from rural areas in the USA, where people would have to travel wide distances, that outcomes were as good as face-to-face. But what you have to bear in mind is that the people who signed up for those studies would have agreed to do that and would have been in principle happy to receive either of these interventions. Whereas now we are in a bit of a different situation where we've sort of suddenly had to treat everyone in this way, and even our most unwell patients. And that, of course, is that bit harder. One thing that some of our patients really struggle with the teleconferencing is the fact that you can always see your own image when the camera is on. And that's really hard for people who have severe problems with their body image, where just to see yourself just sets off a whole range of anxieties. So some of our patients have taken to it just fine. Others really dislike the video conferencing. Then if you switch the camera off, then of course you lose out on a lot of the signals that we usually rely on when we do psychotherapy, looking at people's faces, looking at their body language. Well, that's curtailed with video conferencing a bit anyway. But if you don't have a camera at all, the signals are more limited, and there is more room then for misunderstanding each other. The other thing is that if you have met someone before, of course, face-to-face, it is a lot easier to then also work with them remotely, because you have a bit of a sense of who the other person is. Whereas if you do the whole thing from assessment through all the treatment remotely, that's a difficult thing. And of course, in anorexia treatment, we also need to be very concerned about people's physical health. So some kind of monitoring of people's blood pressure, pulse, their weight, blood tests, there has to be some sort of face-to-face element of the contact, at least for the more unwell of our patients. So it's a challenge to make the changes. The good thing is it's catapulted us into using online approaches much more. It will mean that in future, say if a patient who has started face-to-face therapy, who then needs to travel for their job, they can stay probably in therapy. We can carry on for a bit remotely, and I think we will see for a long time now much more blended approaches, using face-to-face with a mixture of more online approaches, and that can only be a good thing.
Thank you. Yeah, that's really interesting how, as you say, there's been almost a catapulted in terms of the use of these different approaches in terms of more remote therapies. And in terms of the long-term mental health implications of the experience of pandemic for this group, what are those? Do we have a sense of what that might be in in the much more distant future, and how best can we address them?
I'm very interested in early intervention in eating disorders, and I know that very often people don't come forward because they don't quite recognize that they have a problem, they're a bit ambivalent, but also because they don't think they deserve to get help. And in the current situation, I think the message that that we have to prioritize people who have COVID has really gotten through, and there is a concern that some people might not come forward because they feel they're not deserving or their problems are of a lesser magnitude. And we have seen for the moment a real slump in referrals. You hear on the radio how people say even cancer referrals have taken a huge hit. We know that people will go on suffering in silence. So my concern for the longer term is that we will miss the boat for some people in terms of delivering early intervention. Early intervention is hugely important for getting better outcomes. And that would be my greatest concern, that people suffer in silence, that people don't come forward, that people sort of hobble along with their eating disorder, and that their life grinds to a halt. They don't get on with their lives in the way in which they otherwise could. And so that we're going to see more chronic and more people who are really disabled by their eating disorder and end up more severe and then needing more protracted, more intensive treatments.
Thank you. Thank you. That's been a really interesting discussion around this area. Many thanks.
You're very welcome.